We're going to discuss some of the pituitary disorders now, and that can be divided into hypo and hyperpituitarism. Hypopituitarism can be an isolated growth hormone deficiency, or you can have multiple deficiencies, because remember, the pituitary is responsible for various hormones. Congenital hypopit has a multifactorial or different inheritance. These patients sometimes present, for example, with hypoglycemia, persistent hypoglycemia, because they're not regulating things well. Acquired hypopituitarism is any lesion that damages the hypothalamus pituitary stalk or the anterior pituitary, such as radiation therapy. The most common cause of acquired hypopituitarism is the craniopharyngioma. When we are evaluating a patient with short stature, if they're complaining of any visual disturbances, you should think of craniopharyngioma right away. The congenital hypopit, these patients will have normal size and weight at birth, and then they have severe growth failure, both height and weight, cutting across growth percentiles. In the neonate, they can present with severe hypoglycemia and seizures. They can also have hypothyroidism and hypoadrenalism. That would lead the patient to be hypotensive. Also suspected in boys who have a microphallus. Acquired is usually gradual but progressive findings. So that means that they will have atrophy of the adrenal cortex, maybe the thyroid, and also the gonads, because of the whole axis has been disrupted, and these patients may not have sexual maturation or amenorrhea. So that's some part of your differential diagnosis for amenorrhea. If it's an expanding tumor like a craniopharyngioma, which is the most common cause, look for signs of increased intracranial pressure, such as headache and vomiting. The craniopharyngioma, because of its peculiar location, can cause visual changes when it compresses on the nerves. Also, patients can have problems at school. We have talked about papilledema as a reflection of increased intracranial pressure, so sometimes that can be seen on physical exam, and they may also have cranial nerve palsies. A screening test for hypopituitarism is checking for growth hormone. Also, you can see a low serum insulin-like growth factor and binding program. If the growth hormone, if that factor is up or normal, that will exclude a growth hormone deficiency. The definitive test is to do a growth hormone stimulation test and look to see if you can stimulate production. And you can do other tests for pituitary function. Other studies, an X-ray, if you have a destructive lesion like a craniopharyngioma on skull film, you can actually see a large sella turcica because of erosion. The best test, however, would be an MRI, which is even better than a CT scan. The bone age will be delayed. The differential diagnosis of hypopituitarism, think of other systemic conditions and chronic diseases. However, in those cases, the weight is much less than the height affected. Look for a constitutional delay. We already looked at the bone age and chronologic age there. Genetic short stature, look for bone age versus chronologic age and growth velocity. Hypothyroidism, so you will do thyroid function tests as part of your screening. And also emotional deprivation, what they call emotional or deprivational dwarfism. This leads to children who have basically failure to thrive and poor growth overall. The treatment of hypopituitarism is replacement with growth hormone. Hyperpituitarism as a primary condition is very rare, and generally we talk about patients with tall stature. They have tall stature not because of hyperpituitarism, but because they just have tall parents. It's genetic, although sometimes it is associated with certain syndrome. So the most common cause of tall stature is familial tall stature. These syndromes that we've already talked about, such as Beckwith-Wiedemann and Sotos, can also cause tall stature. And don't forget, exogenous obesity also promotes tall stature. Brief list of other entities that can cause tall stature include excess growth hormone, precocious puberty, hyperthyroidism, Marfan's, they're listed there. The evaluation, well, typically you need to know the child's height and plot them on the growth chart. The more points, the better. You also need to know what the parents' heights are. If the parents are tall and the child is tall, most likely this is familial tall stature. Anything that suggests something different than familial or obesity or any positive findings on physical exam warrant lab evaluation. If the parents are tall and the child is tall, you don't need to do anything. If the child is obese, many times the parents will be obese too, and you probably don't need to do any lab evaluation there, you just need to do counseling. But if you see any particular findings that are suggestive, for example, of Sotos or Marfan's or Beckwith-Wiedemann, then you should proceed with lab evaluations. And the best screening test that you want to do is the insulin-like growth factor and also a binding protein for growth hormone. And you can do a glucose suppression test. An MRI, again, is the best radiographic test to look for the size and shape of the pituitaries. Chromosomes are important in males to look for example, Klinefelters, and thyroid tests to rule out hyperthyroidism. Precocious puberty can occur in males or in females, and in girls it's considered sexual development younger than 8 years of age. In boys it's considered sexual development less than 9 years of age. The most common cause of precocious puberty is familial, so you need to get a good history. Maybe mom had precocious puberty, it runs in the family. That's probably what's happening with this girl too. It's important to have, sometimes you'll find an advanced height, weight, and bone age with precocious puberty. So again, wrist films to look for the bone age, and the bone age will be greater than the chronologic age is helpful for precocious puberty. Typically with precocious puberty, since they have that early growth spurt, the epiphyses close early and sometimes their final height isn't as tall. The best screening test is to look for LH, and the definitive test is a gonadotropin-releasing hormone stimulation test. You give this IV and you should see a response in luteinizing hormone. If it's positive, then you should go to MRI looking for tumors. Incomplete precocious puberty includes premature thelarchy. This is usually isolated and transient, but it can also be the first sign of puberty. When we talk about puberty in girls, the first sign is actually breast enlargement or thelarchy, so it could be that they're actually starting puberty, although most of the time it's just a transient finding. Premature adrenarche is the early adrenal androgen production, and then you have premature menarche in girls, which is extremely rare.